introduction from Tara. I've never been called the godmother of OR before. But I do have a bizarre CV in that although I started out doing a maths degree, I then trained to be a nurse. Thank you very much. And so I do have experience from sort of both sides of the bridge, or the chasm, whatever you call it, between academia and the NHS. After I did my PhD, I then became an academic and have spent more years than I care to think about building a lot of different kinds of model for a whole range of different uses in health, ranging from modelling actual disease modelling through to systems modelling. But I've just become increasingly mystified, really, over this period as to why, we saw yesterday in Jeff's talk that OR has been used since the 50s in modelling appointment systems, really since the dawn of OR and the dawn of the NHS coincided. But how come it hadn't become really embedded and become what Jeff called a must-have within healthcare organisations? So rather than actually building models myself, I've become kind of quite passionate about why models aren't, or why modelling isn't just one of the standard tools on the desktop of every NHS manager alongside Excel and PowerPoint. So one of the things that I am interested and become excited about, which very much links in with the ethos of MASHNet, is the Cumberland Initiative, which is a very similar aspirations to MASHNet on a national scale, and is about about linking together the NHS, academia, and industry, consultancy, and software providers, so that we can actually move towards this holy grail where OR is part of the toolbox. So what I'm going to focus on today, when I first sent Martin this presentation, he said it's much too negative. Please give me some success stories. So I really scratched my brain, thinking, do I actually have any success stories? So I did actually manage to come up with two. But then I'm going to talk about the reasons really why I perceive the NHS. But it's not just the NHS, it's actually healthcare organisations globally. It's the same problem wherever you go, that modelling and simulations isn't used as much as it could be or it should be. Then I'm going to talk about a case study that I mentioned, and then just finish off, hopefully on a more positive note, about the way I do see that at the moment we might be actually on the verge of something really exciting. So here's a first success story. This is an absolutely classical implementation of simulation modelling. It was a student project which came out of a bit of consultancy I did with a colleague at Southampton. It was a paediatric intensive care unit. They don't actually spell paediatric like that, but I couldn't bear to spell it the way they spell it. But I mean, it was basically they were planning a new hospital building, and they were going to have some extra beds, and they wanted to know how should they allocate these beds. And at the time, they had a system where beds were they had an intermediate intensive care unit, which was lower acuity, and a high acuity ICU. And they wanted to know should they keep this way or should they organise it by specialty. So they were going to have so it was sort of planning for increased demand in the future in a new building. So how should they allocate these 72 new beds across cardiac, medical, and surgical patients? So as you can see, it's a sort of class. It was built in Simulate. And we had this, what they called this service line provision, was instead of doing it by acuity, it was grouped in terms of medical, surgical, and cardiac. So a couple of students had a lovely time in Milwaukee one summer, and experimented with a whole range of different configurations, and came up with this one which produced the best outcomes in terms of patients being seen in the right place by the right specialists, and minimising the time that they had then to wait to get a correct bed, or etc. But I think that what was really positive for me was that the hospital recognised that actually this was a really useful resource. They did actually offer a job to one of the students, but he was not able to take it, unfortunately. But as a result, they did actually recruit somebody else to do modelling for them. So I think this was an example of a hospital actually seeing for themselves what the benefit of modelling was and deciding this was something that we should really be spending money on. My second success story goes back a really long way, and I apologise those of you who've heard me talk ad nauseam about this project. It was in Nottingham back probably getting on for 10 years ago now, which was a whole systems model of unscheduled and urgent care, which involved every single provider from the social services, the acute mental health services, the ambulance trust, the hospitals, the emergency departments, etc. And it was really looking at the problem of dealing with ever-increasing hospital use of beds, so that they actually had to keep cancelling planned admissions because the beds were full of patients who'd come in as emergencies. So this was a piece of work that took about 6 months. It actually fed into this local framework, so we held a stakeholder day at the end of it, and as I say, and it finally informed what was then the PCT to actually build what's become now a treatment centre actually in the grounds of Queen's. So it was a system dynamics model, a VENSIM model. What was really important, and I think what was the most useful part of the process, was building what we call a patient pathway map, but what Jeff referred to as a shared map yesterday. So it was the conversations that we had with people about how patients move through the system and how the different parts of the system, NHS Direct, the out-of-hours service and so on, all connect up with the other parts of the system. So it was as much to do with the conversations that arose about that than it was about the VENSIM model that actually explored the different scenarios. So I think there were a number of reasons why this was a successful project, which a lot of them, again, people have mentioned while we've been here this week, in terms of having a real urgent problem that was actually meaningful to people and actually involving the right people and getting senior management involvement, all these things, having a charismatic and enthusiastic champion who was actually leading the steering group, who could get the right people in the room to have the conversations. So that's the plus side, that's my positive stories, Martin. Now to the, 176,000 failures, not quite that bad, but again, if you just look at the academic literature, it is a hugely popular area. I mean, there is an absolute massive body of literature. There's no way that a single academic in this field could keep up with the literature. And there's been research papers, or survey papers going back to the 70s, which have looked at the absolutely enormous number of papers and tried to look at whether people are actually implementing and using them. And it's the same story. I mean, this is a really famous quote from Phone et al., that they couldn't reach any conclusions on the value of modelling in healthcare because the evidence of implementation was so scant. And I'm sure that is just something that we're all well aware of. And this paper here, which is published in a fantastic new OR Society journal, which again Jeff very kindly mentioned yesterday, Health Systems, has got 658 references on the uses of OR modelling in health planning. And yet I would question how many of those have been truly implemented, and not just implemented, but actually achieved benefits from the modelling. So I think there's a further step beyond implementing. It's actually getting some positive outcomes from implementing them as well, and documenting that so that you can tell people about it. So I think there's, we could debate for hours what the reason for this is. If you look at what's happening, I mean, there are fantastic examples here, like Pencord, where they've really got engagement, as can be seen by the success of this meeting, with local people. there's Koru in London, there are other places where there have been pockets of success, and obviously journal papers published and models used in the real world, but they don't really spread out and become more widely adopted across the whole of the UK. They just stay within their area, and it's just a mystery why that should be. Obviously there's a lot of work being done by the consultancies, the big and small, but of course they don't publish their work other than in advertising material on the internet. So again, it's quite difficult to actually understand what the models are and what they've actually done. But I think apart from this, there's essentially just this really fragmented picture of what for us in universities is really on the borderline between research and consultancy. So they're kind of mini consultancy or pseudo consultancy projects where you're working with a healthcare partner on a real problem for them. It gets published because we have to publish, but then that's as far as it goes. So the mystery is, why is this happening? Why is it not a must-have? And I think one of the reasons, I'm just going to give you sort of 3 or 4 of the possible reasons. One of the problems is conflicting objectives. There's three groups of people here: the academics, the consultants, and in this case a doctor. We have different purposes of actually using modelling. I mean, in terms of academics, we have to publish in academic journals, in peer-reviewed journals, so we have to do clever, complicated, advanced theoretical models which get peer-reviewed. And that's what we're judged on, and so you're not going to change that system. I mean, it is encouraging that in the ref they're looking at impact, so they are trying to move away from work that is important to other academics to work that's actually important in the real world. In terms of the consultant, these are all a slight caricature. I'm not trying to get at consultants, but obviously it's not in their interests to make their models really easy to use, because otherwise they'd be doing themselves out of a job. So essentially, although say, the sort of the IBMs and the other companies who are doing a lot of work in healthcare, they're not really about educating healthcare people to actually do their own modelling. They're generally more interested in getting them to come back and tweak the model next year to do other things. Whereas the poor old doctor here just needs a simple answer to his problem. He's got to persuade his colleagues that the modelling is useful. So he wants something he can understand and be able to explain to his colleagues, his boss, and he needs the answer next week, not in 3 years' time at the end of a Research Council-funded project. I kind of touched on this. I mean, it is quite hard sometimes to say where research begins and consultancy ends, or vice versa. I've worked in health, as I said, about 25 years. And a lot of the projects I've done, it's really been quite hard to say whether they are research or consultancy, and it depends which it's better for the university to call it sometimes, as to how it gets badged in our finance records in the university. So I think if we're working on real life problems, there's an element of both. And there's the issue of data, which again I think is something that's changing, but certainly in my experience with working with hospital data or NHS data generally, it's not collected for modelling, it's collected for performance measurement and monitoring and performance against targets and league tables and things. So while I'm quite sure the NHS is with terabytes of data, or whatever it was we heard yesterday that it's going to be collecting, and there certainly are techniques, and there are organisations out there who are using this data. Just think of the way that supermarkets use data about their customers to predict all sorts of things. I heard the other day that not only do they know what you bought, but in the barcode it contains the actual sort of the actual value of the food in terms of vitamins and fat and everything. So that actually you can tell a lot about the health status in terms of diet of a population from what they buy on and what's recorded on their supermarket card. So just the thought of what you could do with that in terms of public health, what you know about the population in an area, what they're eating. So I think the NHS undoubtedly is moving towards being able to use these massive data sets, and the whole area of analytics and big data is a really exciting one. And finally is the sort of not invented here problem, the fact that in my experience the way that you get buy-in to a model is by working very closely with the system owners, with the people who actually have the problem, right from the beginning, when you talk about the problem structuring, if you like, understanding what the problem really is. And in a way, I believe that you do have to go through that process in order to actually get people to accept that the model can deal with their problem. And if you try and bypass it or shortcut by saying, here's a model I built for the hospital up the road, let's plug your data in, it's actually quite hard to get people to accept that model would work for them. And you think, how, are there really 1,008 different ways that emergency departments operate? I mean, I'm sure they're all slightly different. Are they all really so fundamentally different that you need to keep producing models of emergency departments, outpatient clinics, whatever it is? So I think there's an issue here for academics in really understanding which parts of that process, that model building and engagement process, you actually really have to go through, because it's just an essential and painful part of the whole modelling project. Which parts can you shortcut, and how can we work together so that we can actually get the buy-in without going through the months of discussion? And again, I think this is something which I'm feeling more optimistic about. There has been issues, a sort of culture clash between the NHS side, which, in particular clinical side, who are taught in their whole training is ingrained in them to think of people as people and not as widgets inside a computer or objects on a production line or something. And so the sort of philosophy of modelling that you can model a hospital system like you could model a factory, people just find that quite culturally difficult to accept. But I think, but as I say, I think again this is something which is changing as people get more exposed to these ideas earlier on, and they've just become more acceptable. And of course the issue we talked about the fact that people are just so frantically busy dealing with today's problems that they don't really have time to step back and think about what might happen tomorrow. How might we do something slightly better rather than just firefighting today's issues? So this project, it's a sort of follow-on project from the one that Martin was talking about this morning, Torch. It was done by roughly the same people that took part in the Torch project. It was Mashnet was asked if they could do this work by the NHS Institute and Nick Grant. It was about a particular software project, which I'll say a software tool, which I will say a bit about. But actually, the overall learnings from this project were very general, and in fact more general than just simulation. They could actually apply to the whole of OR and modelling in general. And it has just been published in the Journal of the OR Society. So it's about scenario generator, which there is a stand outside in the other room over there. And Claire is here somewhere. So if you've got any questions about scenario generator, please ask Claire, don't ask me. But it was offered initially to all PCTs and public health organisations, and I think maybe one or two other groups as well. Back in 2008, I think. Free of charge they could have it free for a whole year, and they could also have 2 days of training and then online support with it. And then at the end of the year, they then had to decide whether it had been valuable to them, and they would actually purchase a license. So it's Claire who was the Simulate person who looks after this tool and does the training, and she came and trained us. So, I mean, it's a version of Simulate. It's a very specialised version, which rather like, in a way, rather like the Torch toolkit is aimed at a particular function, aimed at people who are planning services. And so it comes with a massive sort of inbuilt data set of incidence and prevalence of diseases and population data in terms of births and deaths and things, broken down by individual practice or PCT or city, however you wanted to slice the data. And this is what it looks like. So if you're a simulation person and you've used Simulate or you've used this tool, you basically build up your pathway on the screen by using these little icons, and you connect them up to show the way that patients flow through the model. And then it automatically creates the incidence year by year of whether you're looking at stroke or diabetes, whatever it is. And then you can route that, the actual activity that those patients generate in terms of GP visits or outpatient visits, whatever it is, along this pathway. And you can see whether you've got sufficient capacity to cope with it, and maybe you need to put in some extra resource here for inpatient care, whatever it is. Sorry, this thing's a bit random. It sometimes works, it sometimes doesn't. Anyway, what we were asked to do was to actually look at the people that were using this tool and some of the people who weren't using it, for those people who were using it, to find out what they were using it for, if they weren't using it, to find out why not. And really some of the issues which link in very closely with the Torch project was what skills need to be there in the organisation for people to be able to use it. And it was, as I say, although it was specifically about this tool, the general issues were much wider than this. So here were the team of people from the different universities who were involved in it, largely similar to the people that did Torch. And so what we did was we looked at the literature. We started off looking at the literature, and we also attended a session which Claire had organised amongst the SG user group up in Warwick, and then tested this framework. And then we did a number of semi-structured interviews, really, that were based on the literature across the whole spectrum of people who hadn't used it, people who had used it. And the aim was to see what things helped and what things hindered the use and take-up of this tool. So while a few of the things were kind of really specific to this particular software, a lot of what we found, and this is what was published in the JAWS paper, was much more general. And so I think overall we were looking not so much at the use of modelling by people coming in from outside, so academics and consultants coming in and doing modelling for an organisation, but what needed to be there within the organisation so that the NHS staff could then use the tool themselves. And I'm very strongly of the belief that that's the way forward, that it's only once it becomes as common as Excel, once these tools are on everybody's desktop and they think, there's no way I would dream of designing my new intensive care unit without doing a simulation, then I think that's when we will have actually cracked the problem. So we had these three groups of people. There were the people who had the license, they'd been trained, but they'd never actually used it. Then we'd had people, which I thought was the more interesting group, the people who had used it for maybe one project and decided not to take it any further. And then we had a group of what we called active users, who were the people that had used the tool and had found it helpful and had achieved benefits from it. So this was just roughly the sorts of people who were using it. So this is group one, the people who'd never used it. These were the people who had used it, and stupid thing. If I keep doing that, you can see it. These are the people who had used it. These were the people who were actively using it. And at the different levels, which the analysts are the people that you would expect to use it. These were the IT people in a trust. Interestingly, some of the more senior people had it, and there were more people amongst the group who had tried it and then given up in senior management in proportion, although the numbers are quite small. And then we had the people whose particular role was in sort of middle management here. Again, were the people who hadn't used it. There were these 8 general areas in the questionnaire. So we looked at the individual people themselves, what skills they had, and then the organisational skills that they, or organisational help that they got. So were they actually given time by their organisation to actually get to grips with the tool and so on. And things like if they could compare it with other tools they used, which were mainly Excel-based things, how easy did they find it, and so on. So this was these overall areas, these 8 overall areas here, and so what we did was we actually coded the interviews. So we had the interviews all transcribed, and then we looked for certain keywords that were looking in these things in the framework. So there were organisational things up here, organisational features, external influences like world-class commissioning, etc. And individual things, and social things as well. So was it something that was generally perceived in your department as being a good? Were people interested in what you were doing, or were you very isolated? You were the only person that did it, and so on. So obviously, in this particular case, ease of use was seen to be a problem. In other words, it wasn't very easily useful, whereas external factors were a thing that were actually driving people to use modelling. And so I'm sorry, these colours haven't come out. They're beautiful on the laptop. They all look yellow, but it's what you'd expect. In group 1, these are the people who have been trained but haven't got round to using it yet. They're predominantly amber because they hadn't really, they were equivocal. They hadn't really had enough experience to. There were a number of reds up here, which is about fit and ease of use and so on. Whereas group 2, there aren't any greens at all, believe me, and they're mostly red. So these were organisations where they had actually struggled to use it. Whereas the people that are actively using it, again, you'll have to take my word for this, they're all green, or nearly all green apart from that one. So it was kind of what you'd expect. I think rather more interesting was the sort of qualitative comments that we had. So in terms of whether people thought it was worth their time, and whether the kind of ROI that they would get in terms of both money and time of staff were again, people in group 1 were just not really convinced it was worth the effort of getting to grips with the tool, whereas group 2 were absolutely sure it wasn't, which is why they'd given it up. And whereas group 3 really saw a very strong benefit to them. It was definitely worth the money, although there were still some caveats about senior management. I mean, obviously the fact that it was free at the time was a very big factor, and I think it was certainly the fact that it was provided free, and not just the license but the support was a large factor. But people did realise that actually just because it was free, and I think again this is a warning for us, just because you provide something free doesn't always mean that people are going to take it up. I'm sure for some people they think that because it's free we're not really sure it's very good. But also there were other hidden